Well, good afternoon, everybody. You are attending a webinar in the series organized by the EURO-NMD. This afternoon, it's an imaging webinar, and we are lucky to have two excellent speakers, two experts in the field, two recognized worldwide for their competence, expertise, and productivity in imaging of neuromuscular disease. First speaker will be Giorgio Tasca. He's professor at the John Walton Dystrophic Research Center. And our second speaker will be Harmen Reyngoudt, a team leader at the Institute of Myology. They have a lot to say, so I will not do a long introduction. They know by, I'm sure, most, if not all of us. So, Giorgio, the floor is yours.
Well, thanks a lot, Pierre, for the kind introduction. So the idea of today's presentation is, as you read from the title, to provide you with an update on the diagnostic imaging with a focus on MRI, of course, in neuromuscular diseases. And this is the layout of my presentation. So the idea here is that, again, to give you a non-comprehensive overview of with a few highlights of what happened in the last few years in the field of diagnostic imaging. And so apologies in advance if I will miss some things that might be of importance. So this is again the layout of my presentation. So I'll focus on large core studies first. And then, of course, you need to interpret this large in the context of rare neuromuscular diseases. So the numbers will be relatively small. And then I will speak about even smaller cohort studies and or case reports. And then I will finally focus on new or recently discovered diseases. So again, these are the large cohort studies I plan to discuss about. So all of these basically were confirmatory studies. So none of these actually showed a completely new pattern, but of course they were helpful to confirm previous findings and expand the imaging spectrum of these diseases. So let's start with this study that collected a large number of scans of patients with neurogenic muscle disease, and in particular of hereditary motor neuropathies, and try and understand what is the usefulness of muscle imaging in diagnosing those. So what are the general features that you will expect to see on an MRI scan of a patient with a genetic motor neuropathy? Well, the first feature that the authors highlighted here is the proximal distal gradient of muscle involvement, which is of course compatible with the axonal dying-back mechanism of these diseases. Another feature that was highlighted, and you see a clear example here, is the sometimes very prominent asymmetry. The third one, which is quite important, is this type of texture that is defined as reticular texture or muscle islands, that is characteristic of chronic neurogenic disorders, which basically means that you can have high islands of intact muscle tissue that is surrounded by fat. The third feature that can be displayed in this context is this hyperintensity on the STIR images, which is more of a feature of acute denervation rather than chronic one. And also the authors in this study were able to highlight specific patterns that were more suggestive of particular gene mutations. And you see here, for example, on the left-hand side, the pattern that is typical of what we call SMA-led type of phenotype. So an SMA with lower extremity dominance. And these are the two genes known for being causative of this disease, and the typical pattern that is again constituted by this muscle island type of fatty replacement of the quadriceps, with the sparing and hypertrophy of the adductor longus muscle, which was already highlighted in previous older publication, and this sparing and hypertrophy of the extensor hallucis longus as well, while the tibialis anterior is more severely affected. This is clearly different from what you would expect in diseases with mutations in aminosyl tRNA synthetase genes, where the involvement is much more distal and much more prominent in the anterolateral lower leg compartment, with the tibialis posterior that seems to be spared even in advanced disease. Again, something a little bit different from what you would expect to find in patients with mutation in HSPB1, which actually causes a type of a neuromyopathy phenotype, and where the involvement is more severe in the posterior lower leg, so in the calf. But then, of course, this is extended also to the anterior lower leg and the proximal thigh muscles here. Let's move to more the myopathies, and this is quite a large study, as you may see, that aims to characterize the muscle imaging pattern in nemaline myopathies. So the authors here focused on three main genes, so nebulin, which causes a recessive form, ACTA1, which causes a dominant, and tropomyosin 3, which is another dominant nemaline myopathy. And you can see that the involvement is reported to be different with the lower distal lower leg, anterior compartment, and soleus in nebulin, while a different pattern is reported in ACTA1. And I would like you to focus your attention on this, which is the sparing of the adductor magnus here and the involvement of the sartorius, which is a combination of findings that is in general very, very unusual in myopathies. Of course, this is not totally specific for ACTA1, and this is something that you might find sometimes also in nebulin, and again, not necessarily all the ACTA1 mutated patients will present with this, but just keep that in mind. While with tropomyosin 3, you have a much more diffuse type of involvement with sparing of the rectus femoris, adductor longus, and quite sensitive finding is this involvement of the tibialis posterior. I would like to make you focus on the fact that even these patients that they showed actually has a type of a muscle island texture of involvement that, of course, you have to consider this with some attention in terms of the differential diagnosis. So it's not 100% specific for neurogenic. Let's move to a different gene, which is titin. Now, despite the interest that this gene has raised in the last years in terms of the popularity for the recognition of mutations in these genes, and also the difficulty in interpreting the findings, actually, this is probably the first paper that systematically collected and focused on the imaging findings of patients with mutation in titin genes. And this paper specifically focused on recessive titinopathy, so patients with biallelic pathogenic variants. Most of them had a congenital myopathy type of phenotype, and you can already see how heterogeneous the involvement can be. All these patients look quite different from one another. The kind of common denominator that the authors found was, in any case, the involvement of the semitendinosus muscle that you clearly see here, for example, particularly in the most proximal part. And this is another extremely recent paper, actually, that focused on imaging involvement in two other distinct forms of tendinopathies, which is the HMERF on the left-hand side, so the phenotype with the hereditary myopathy with early respiratory failure, and on the right, the prototype of tendinopathy, which is the tibial muscular dystrophy. And so the main finding was that they look pretty different on MRI, with the typical involvement in HMERF, which is again characterized by the involvement of the semitendinosus here, the obturator externus muscle, and they also flagged up this peculiar kind of affection of the gluteus maximus muscle in the most medial part. So this is very different from what you see in TMD, so in tibial muscular dystrophy, where of course the tibialis anterior, as the name says, is the first muscle to be involved, but the patients can also have posterior thigh involvement, which is very often asymmetric, but also, quite surprisingly, some changes in the glutei muscle, especially the gluteus minimus and the gluteus medius. Now, this is a completely different category of diseases, which is the inflammatory myopathies. And what I found interesting in this paper is that you usually focus on the pattern and the type of muscle involvement that you see on T1 weighted sequences. So that, of course, depends on the distribution of fatty changes in the muscle. In this paper, the authors focused a little bit more on the different patterns that you can have on stir sequences, and they described these 6 different types of involvement and try to correlate the type of involvement that you see on MRI with what you see on histology, and the result of it, and also whether this could distinguish the different. Also, whether this could distinguish the different.
Depuis le PC, quand tu déconnectes depuis le PC, ça ne marche pas.
Yeah.
Quand tu fais un clic droit sur le nom de la clé, il n'y a pas l'option éjecter.
Intéressant.
So Pierre, I think if you could mute the mic.
Non.
Yeah, thank you. So they try to correlate this with the histology on the one end, and also to try and understand whether this would help distinguishing the different serotypes that you can have in these diseases. Now, the association is not that straightforward, and of course it works quite well when you want to correlate the type of involvement that you see in the fascia on MRI and histology. It works less well when you try to distinguish the distribution of the inflammatory infiltrates in the muscle based on the stir pattern. So another important advance in the last few years was the introduction of imaging, and specifically both MRI and ultrasound as a supporting diagnostic criterion in IBM, so inclusion body myopathy, so that according to these revised criteria, you can use imaging to support an IBM diagnosis, especially when you have some atypical presentations or incomplete presentation. Of course, this needs to go alongside the clinical and, importantly, the myopathological findings. And this was based on basically on the description of this typical MRI appearance, which in IBM is basically this peculiar aspect of the distal quadriceps that looked fatty replaced, atrophic, and sometimes also melted and associated with an hyperintensity on stir sequences. Now, we have recently tried to revise these criteria to make them more scorable, because of course the term typical can be somehow ambiguous. So what we did was try and identify specific criteria for IBM, and we proposed 3 major and 3 supporting criteria, with the major being, again, the distal fatty replacement of the quadriceps that needs to be more evident than the replacement in the posterior thigh. The distal quadriceps needs to be hyperintense on stir, and these are the 3 main criteria, while the supporting one for IBM are the involvement of the sartorius muscle, the relative sparing of the pelvis, and the predominant involvement of the medial gastrocnemius at lower leg level. We also tried and defined the muscle involvement in the upper body in IBM patients, and what we found is that there is some, even though milder compared to the lower limbs. And in particular, the intracranial muscles, at least the ones that you can easily assess on standard MRI, appear spared, including the tongue and the masseter muscle, while there is some mild involvement of the neck muscle and the periscapular, and this is more prominent in the paraspinal muscles. Let's move to another large cohort study that addressed the importance of imaging in distinguishing dysferlinopathy, this time from the other diseases. And the authors here, they were able to collect a very large number of scans, because they compared 200 dysferlinopathy scans with 100 of scans of other muscular dystrophies that you see here. And the take-home message of this study, where they tried and define rules that would help you to distinguish dysferlin from other genes, was that you can build up these rules and achieve a very good sensitivity, almost 96%. But unfortunately, the specificity of these rules to distinguish from other limb-girdle muscular dystrophies is relatively low. So what can you do to increase the specificity of your MRI-based diagnostics? Well, one thing you can do is, for instance, to try and compare at the global level, the level of involvement that you have in specific muscle groups and muscle areas. So one typical finding that you have in dysferlinopathies, for example, that the pelvis as a whole is relatively spared compared to the thigh and the lower leg. And another way of increasing your specificity can be, of course, extending the body segments that you study to include the upper body. And this is something that we have tried to do in sarcoglycanopathies, where we have quite a consistent pattern in the lower legs. But we found that studying the whole body imaging, so including the trunk, the upper girdle, and the cranial muscle, adds something in terms of your differential diagnostic power. So what are the muscles that are more affected in sarcoglycanopathies in the upper body? I mean, it is important to know that the tongue is not really among the muscles that are usually affected, and this is important because this is an helpful differential diagnostic clue with Pompe disease, while at the scapular girdle level, you have the subscapularis, which is similar to Pompe, but also one of the earliest muscles that is involved is actually the latissimus dorsi. And we find the same proximodistal gradients that we had identified in the thighs, for instance, also in other body segments, such as the biceps. You see it here that the proximal biceps is more involved than the distal part. And this is another study that actually focused on quite a rare type of disease, which is the oculopharyngeal myopathy. And the authors here, they collected, again, a large cohort of these patients, more than 50 patients with 3 different genotypes of OPDM, and they were able to show that actually from an imaging standpoint, there are no major differences in these three different genotypes, while the muscle imaging phenotype is very much different from the OPMD, so the oculopharyngeal muscular dystrophy, which has in common with the OPDM the sum of the clinical features and some of the muscle pathology features as well. So what are the muscles that are more involved in OPDM compared to OPMD? OPDM clearly affects more the lower leg, and in particular it starts from the calf and then affects the anterior lower leg compartment, while of course in OPMD you have a much heavier involvement of the adductor magnus in the first place and the soleus. Now let's move to the second part of the talk, which focuses on case reports and small case series. So the first gene that I would like to discuss is PAX7. Why? Because of course PAX7 is a master regulator of satellite cells, so it's a gene that is super important for normal muscle repair and homeostasis to some extent. And a congenital myopathy with biallelic mutations in PAX7 has been recently described, but before that paper there were no descriptions of the imaging findings. So which are the muscles that are more kind of reliant on PAX7 function? So which are the muscles that are more involved in this type of disease? So what the authors reported is a predominant involvement of the axial muscles, including the neck flexors and extensors, so the sternocleidomastoid, but also the occipital muscles, and also the paraspinal muscle at thoracic and lower back level. While the most affected muscles at thigh levels are actually the sartorius, the adductor longus that you see here, and again, the proximal part of the semitendinosus. Now, this is just a case report, but I wanted to present it because it tells you that, you know, sometimes the imaging findings that you have are not necessarily that specific and not necessarily so much aligning to what is known. So this was a case of an Emery-Deyfus muscular dystrophy type 1 patient, so mutation in the Emerin gene, so one of the X-linked type of EDMD. And this was a 13-year-old patient, and you see that the imaging findings are I would say everything but specific, because besides the this minor involvement in the tongue, there is again some paraspinal muscle involvement, very diffuse but not specific involvement at thigh level, and again quite diffuse, maybe with this anterior lower leg predominance at lower leg level, and also this particularly interesting type of involvement at gastrocnemius medialis level with this rim of fatty replacement. And now you see here that so far what has been described in the literature is quite heterogeneous in terms of the type of involvement that this disease may show, with probably the most consistent finding being again this anterolateral lower leg involvement, which of course matches with the classical clinical description of Emery-Deyfus having the dystrophy, having the scapuloperoneal type of phenotype. And this is again one probably unusual finding. So we described these two patients with homozygous variants in BVES, which is also called POPDC1, which is a gene known for being causative of a type of recessive limb-girdle muscular dystrophy that is now defined as LGMD-R25. So this specific variant actually does not significantly affect the membrane trafficking of POPDC1 and associated POPDC genes. So a minor impact on the localization of the protein. And the phenotype was quite peculiar from an imaging standpoint, because one patient had actually a distal myopathy phenotype, so a calf myopathy with involvement of the gastrocnemius medialis bilaterally that was also stir positive and nothing else. The other patient had a type of ANO 5-like, that's how I would define it, phenotype. So a relative sparing of the pelvis, adductor longus and magnus involvement at the thigh level, gastrocnemius medialis here, and very much widespread stir hyperintensities that were also reflected by the very high serum CK levels. Last part of my talk, I would like to focus on a few more recently described genes, and I'm gonna speak about actinin 2, snurportin 1, and if you would allow me to also make a small digression on that, and then this other type of myopathy, dominant myopathy with contractures caused by variants in the MAMDC2 gene. So let's start with ACTN2. So alpha-actinin 2 is a Z-disc related gene that is usually expressed both in skeletal muscle and heart, and has been recently associated with a type of distal or congenital myopathy. So the authors here, they collected a significant number of patients with the dominant non-congenital actinin 2 mutations. So what are the muscles that are more involved in the disease? You see it from this heat map here. So the glutei muscles, the posterior thigh muscles, and the tibialis anterior, and maybe also the soleus at lower leg level. If you look at this picture, you see that actually the type of muscle involvement is again quite heterogeneous, and also it also has some asymmetry, and this again, this sparing of the adductor magnus sometimes, which seems to be even though not a fixed feature of this disease, seems to be a recurrent finding that you may have in mutations in sarcomeric proteins to some extent. And I would say that this resembles very much what you might see in titin or in FSHD, and of course the authors wanted to understand which muscles were more helpful to distinguish ACTN2 from FSHD, and they come up with the fact that the soleus and the gluteus medius are more involved in ACTN2 compared to FSHD, while the biceps femoris shorted and the gracilis are more associated with FSHD. And this is another rare disease that has been recently described, so snurportin 1, which causes, again, recessive limb-girdle type of muscular dystrophy. So snurportin 1 is a protein that is associated with the function is basically, it has a role in the trafficking of small ribonucleoprotein to the nucleus. And so if this process is affected, you might expect having an impact on the splicing of several genes. From a clinical standpoint, this is associated with again limb-girdle type of myopathy with prominent contractures, axial type of involvement as well, and respiratory impairment. The muscle pathology is characterized by this myofibrillar myopathy-like features, and they reported the imaging findings in two families, with the most recurrent features being the quadriceps involvement here, together with the sartorius and gracilis, and of course the paraspinal, which reflects the axial component. This has been recently confirmed in another paper describing one additional family, and you see that again the patients here have this axial involvement with the quadriceps and the sartorius and gracilis. Lower legs are relatively spared, with maybe some changes at the calf level, and again these myofibrillar myopathy-like findings on biopsy. But what I want you to focus on is that, again, these muscles, they seem to show this type of reticular or inhomogeneous type of involvement, which is a little bit borderline between what you would see in neurogenic disease and what we would call fat pockets, which are typical findings, which are quite consistent findings in some specific myopathies like BCP. And so if you would allow me this digression, so I wanted to reflect a little bit on which are the muscle diseases that would show these fat pockets. So what are these fat pockets? So the fat pocket, a typical fat pocket is this one here. So it's an area of very compact fatty replacement that is surrounded by a normal muscle. I mean, at least to me, the distinction between these and the muscle islands, especially in advanced cases, can be very difficult. But this is, again, a finding that has been described under several names, like patchy area, patchy involvement, geographical areas of muscle fatty replacement, but has been typically, again, associated with BCP in the first place. But the reality is that this is something that you find in other diseases as well, whether they are other multisystem proteinopathies like ANXA11 or FHL1. It does show the very similar type of pattern, but not only that. So you could find something like that in some forms of glycogenosis, like this patient with variants in the glycogenin 1 or even phosphofructokinase. In these other patients here, you see these patchy areas of fatty replacement here and there, and in the glute muscles as well. But this is also something that you find in some myofibrillar myopathies. And of course, even though it was not specifically highlighted, the impression is that this might be a very consistent finding in myotendinopathies, for instance, which is something that we were able to confirm with a large case series of distal myofibrillar myopathies that we are currently trying to publish. So what are the diseases with fat pockets? So in general, these are myopathies in which there is some accumulation of material, whether this would be multisystem proteinopathies, myofibrillar myopathies, a neutral lipid storage disease. You see it here. Typical fat pockets in a case of neutral lipid storage disease, so where the patients do accumulate lipids in their muscle, or they can accumulate glycogen, for example, or they can have defect in some chaperones. So there are probably others as well. So the question is whether this underlines a common pathomechanism or not. And I would like to finish with another disease where I think that, MRI is very, very important from a diagnostic standpoint. This is a new gene that is called MAMDC2. It is not clear what the gene does, but what the protein does, what is the function of the protein, but it seems to be involved in extracellular matrix remodeling to some extent. The clinical phenotype of these patients is very similar to Bethlehem myopathy. So you see here that they have, again, a dominant myopathy with these prominent contractures, especially the finger flexor contractures. And the interesting finding is that likewise on MRI, you see the collagen sign, so the rim of fatty replacement under the fascia of the muscle with the area of internal sparing that is very clear in some of the muscles, especially the quadriceps. You see it very clearly here. So again, is this specific to MAMDC2 or collagen 6? Probably not. There are other diseases with collagen-like appearance of the muscles, but the interesting finding is that, again, besides calpain-3, all these other genes, JAK2, LAMA2, MAMDC2, and von Willebrand factor-associated protein 1, they do have, which actually causes a neuromyopathy phenotype. they all have a role in the extracellular matrix homeostasis and interaction with the muscle fibers, again, probably underlying some common pathomechanism and selective vulnerability of, in this case, not specific muscle, but specific muscle region, which is, of course, an interesting finding from a pathophysiology perspective. And with this, I finish. And of course, I am totally happy to get some questions.
Yeah, well, thank you very much, Giorgio, for this very detailed update on the diagnostic imaging. I don't know if we have questions before we hand over to Harmen. Okay, well, so we'll let people think a little bit more. I have a few questions for you at the end, but then, okay, floor is yours, Harmen.
Okay, thank you, Pierre. Thank you, Giorgio. I'm going to immediately start. My presentation, or this part, is going in another direction. It's mostly MRI, but it's from the quantitative aspect point of view. So I'm not going to show you as much images as Giorgio, but it's more about the values that we extract from them. I hope my slides. Okay, so just a small disclosure. So it's the emphasis in quantitative MRI, although the title says imaging. There is a little bit of ultrasound and MSOT. I will talk mostly about skeletal muscle applications. There's also some information on the important acquisition parameters in the context of QMRI. So that can be important if you want to set up protocols, or at least some things to think about. There are some examples of imaging and QMRI in muscle NMD in 2025. So it's not a comprehensive overview. There are some examples of anatomical targets that I will miss out, such as heart and the nerves. So, and there's no comprehensive literature survey of the last couple of years. So these kind of images you have seen in the presentation of Giorgio, so I'm not going to talk too much about that. Just making the link with quantitative imaging. So most of the data that were shown in the first part were T-weighted MR images. So more or less, the brighter the signal, the higher the fat contribution. There were some examples. We've seen also an example of patterns on stir in inflammatory myopathies. So these are the T2-weighted MR images. They are corrected for the contribution of fat, and these have hyperintensities. And the brighter the signal, the more hyperintense, of course. And these can be linked to a higher level of inflammation or edema, but not exclusively. So if we take a look at this slide very shortly to make the link with imaging. So if we have an injury in muscle, and this leads to inflammation, and there's the cycle of regeneration, at some point there will be a vicious cycle where the chronic injury and the chronic inflammation will lead to fatty deposition and fibrosis, and we will be in an advanced stage of the disease. If we then translate that to the imaging and even function, so we again these same images where you have this muscle fat replacement on the T1 weighted MR images. Before that, probably there was some kind of early signs of disease activity or active muscle damage, so which we can extract from the T2 weighted MR images. But further down the line, this will lead to clinical signs such as the loss of function. So this is an older picture, but it's still very useful for didactic purposes from the Imaging NMD Consortium, where you see that fat fraction can increase to high levels without any effect on the function, and then at some point it's very crucially drops. So let's focus first on this middle part, on the muscle fat replacement. So quantitative imaging for muscle fat replacement, they're mostly done with chemical shift encoded sequences. So more or less, you just acquire at multiple echo times, at least you need to have two. So you get these different kinds of contrasts, which we call an in-phase magnitude image, an out-of-phase. So these are Dixon type sequences. You know that as under the Dixon name. This can lead then to a water image and a fat image. So this is basically, like I said, so this is a chemical shift. So it's based on on the frequency separation between the hydrogens we find in water and fat. And so you can, with these images, you can even appreciate that this looks like a T1 weighted image. So you could use them as a replacement to if it's high resolution and if it's nicely acquired, you can also look at the patterns here. But you can combine them to get a quantitative fat fraction map. And from this, you have spatial information and quantitative information. So just to say, well, this is a very small, let's say, cartoon spectrum, but in fact, there are multiple peaks for lipids. To show you here the triglyceride molecule schematically, and you see the different colors. So the different kind of protons will lead to different kind of fat peaks in this spectrum. So most of nowadays, Dixon imaging, we use not a single peak, but a multi-peak model to quantify fat fraction. So most of the Dixon type sequences you find on all major clinical MRI systems. Most often they are 3D. We have to be cautious with the acquisition parameters because not all of these Dixon type sequences are proton density weighted, and that's actually what you want. For spectroscopy, it's an accurate assessment of proton density, but most often it's only in a very small volume of interest. So you have to also be cautious with the choice of acquisition parameters, as with all quantitative imaging modalities and spectroscopy modalities. So this is again an image of the qualitative T1 weighted. We can nicely put the fat fraction maps beside it, and then if we compare, this was done some time ago. Also, something that comes back always in sort of educational presentations about QMRI, is you see that there's a wide range of fat fraction values within the same semi-quantitative score. This is done with the laminin mercury score. So we have the limitations when we want to use quantitative fat fraction, at least a quantitative fatty water imaging for instance, longitudinal purposes. So you really need quantitative. So it's a very charged slide. Just very shortly, here in this panel, you see that these are fat fraction maps. So this is not T1 weighted imaging. So you have a visible fat fraction increase on these fat fraction maps. So you can actually appreciate them and visually inspect them and see that there's an increase in fat fraction on these maps. If you then look at this middle panel here, so there's a fat fraction increase which you would not see on these images. You cannot really discern if it goes up, if it goes down. So you have to really go to the values, and you will see that there are significant increases even if the naked eye cannot see it. So that's why we need quantitative fat fraction or fat water imaging for longitudinal follow-up. So we often use the standardized response mean, so to measure the sensitivity to change over time. These images can be used to also measure the residual muscle tissue. You can do that on a single muscle volume or also the global segment. And fat fraction has, in the last couple of years, also been used to model them over time to predict future disease progression. So there have been numerous studies in Duchenne muscular dystrophy. This is an example from dysphalanopathy, but this works to some extent. But due to the heterogeneity of these diseases, there are many factors that we don't take into account, and probably will need to be taken into account if we ever want to use these kind of trajectories to predict future disease progression, at least with accurate estimates. Some examples from the last for the last year, actually. So this is in Charcot-Marie-Tooth, where they compare the progression in calf muscle over 12 months to the 4-year change in the functional score. This is done, I mentioned always the magnetic field strength and the Dixon that's used, so 3-point Dixon, so that means it's 3 echo times. It was done in 20 patients. This is in myonic dystrophy type 2. So here they used the 6-point Dixon, so that means that they used 6 echo times. So in 37 patients and a big cohort of controls where they did a little bit more. So they just didn't stop at measuring the differences between the DMD patient, two patients and healthy volunteers, which they found. There was a clear correlation with age, which we also see in the healthy controls. And we see that there is also a deterioration with age when you look at muscle. So this is the lumbar paraspinal muscle, where you see that the offset is constant over the age. And you see here in the psoas muscle, where there's really an additional effect of age in these patients. There are also some studies where they use treatments. This is in a Duchenne muscular dystrophy in a rather large cohort where they 39 patients, 19 on gene therapy, 20 in placebo, and where they showed that there was a slower disease progression in the gene therapy group. So you see the dark blue here are the ones that were on the gene therapy. They found these significant differences with spectroscopy, and to some extent they also found these differences when they used imaging, quantitative imaging. This was done with an 8-point Dixon. Also in inclusion body myositis, this was an older study, if I'm correct. So this were 18 patients, 8 on arimoclomol and 10 on placebo. Earlier they found that there were no effect on functional outcomes, and more recently they published that when looking at more in detail to the quantitative MRI outcomes, that also there they did not find any differences between the placebo and the treatment and the treated group. And then in neurodegenerative motor neuron disease, amyotrophic lateral sclerosis, they also find very interestingly significant differences. Muscle fat fraction is lower in these diseases, but they could find a significant increase in some patients in the thigh, in the lower leg, and also in the hand. And the emphasis in this study was also this was in patients that were on gene therapy too. There were no controls, and they found that there's potential use of quantitative MRI in clinical trials of ALS patients. Of course, automatic segmentation of muscle is very important when we go to whole body and to upper limb muscle. So we need to. So manual segmentation has been taken over more or less by these tools. I'm listed here a number of papers that have come out recently in the last couple of years about automatic segmentation. So you can go and find out yourself. There's an example here in facioscapulohumeral muscular dystrophy where they went one step more. So they used this automatic segmentation to really look at the impact also on function and force. So this is the tibialis anterior muscle of 12 FSHD patients, and they investigated where the proximal distal muscle fat replacement, where this fat distribution was, and how it had an effect on muscle force. So that's the muscle fat replacement. So this leads to the further down the line to a loss of function. I don't have time to go into that. That's for another webinar. I'm more going to talk about the early signs of disease activity. So other imaging biomarkers that can be used to go and look at active muscle damage. So the first one is water T2, T2. So it's a property that's tightly linked to the mobility of water in tissues. It's an MRI property. It's a QMRI biomarker sensitive to changes in active muscle damage. So this can go from inflammation, edema, necrosis, denervation. So it is not a specific marker, but it is very sensitive. So again, a crowded slide, but I let you appreciate in your own times. You just have, you need a multi-T acquisition. You acquire different echo times. There are different ways of post-processing. There's also, you can also do it with spectroscopy. You need to just have also multiple echo times. And again, you separate nicely frequency between the water and the fat peak, and you do mono-exponential analysis of the decay, and then you can extract your T2. The advantage of this is that all major clinical MRI systems have these multi-TE sequences. Most often they are 2D. That's what is illustrated in the figure here. So you can acquire multiple equidistant slices with gaps where you don't have information, but there are also 3D approaches. They are less frequent, but they exist. You need to really take into account the contribution of fat here, specifically in muscle diseases, where you have always these muscle fat replacement that plays a role. So when you do your protocol or when you read papers, always look at how many echo times were used, look if the acquisition take into account fat saturation, and if in the post-processing they were also taken into account. So look at what the reported T2 is, if it is global T2 or if it is muscle water T2 for interpreting correctly. So spectroscopy, again, it's an accurate measurement of water T2, but it's in a very small volume. I'll come back to this and also in further slides. If you compare the qualitative water T2 mapping here, so you have a sort of stir image here where you see here these hyperintensities, and when you do then the water T2 mapping, you see that this collates nicely. You have these high water T2 values you found in the gastrocnemius medialis here. And if you compare it like for fat fraction, you see that there's a wide range of water T2 values within the same qualitative score. So again, the impact of fat on T2. So this is the illustration here. If you don't take account the fat, you see that your T2 goes up with fat fraction. So you have almost a correlation of 1 here. So you don't have any information about disease activity. It's only the same information you extract with T2 as with fat. Otherwise, if you take into account the fat, you see that the water T2 is not impacted by the fat, maybe a little bit when you go to higher fat fractions, but you are more or less uninfluenced by it. And we see this recent paper in 2025 in SMA type 2 and 3, where the authors, they report a correlation of T2 baseline fat fraction without nuancing that it's actually the same measurement that they use. You see it's very much the same as we see here. You only extract information almost on fat and not on any other biomarker such as inflammation or edema. Even if you take into account fat fraction, you see that this is in Duchenne muscular dystrophy. You go to 70, 80, 90% fat fraction. There's still an impact of fat fraction. So the message is always interpret this with this information in mind. So I talked about 3D imaging with T2. So here's an example in facioscapulohumeral muscular dystrophy. So in 10 patients, they did a 3D T2 map, so in around 2 minutes, 30 8 millimeter slices, so with 80 echo times, and they used fat saturation during acquisition. So this is a fast 3D T2 map in a short acquisition time, which is a change of what the authors presented a few years back. Here they compared conventional acceleration that was on the scanner with a deep learning based acceleration. They showed similar T2 maps, and you see that they accelerated the acquisition. Another study was more also this year, where they published a comparison between the T2 multi-slice multi-echo sequence, which is a little bit of the used sequence, which is on all vendors. They compared it with the 3D partially spoiled gradient echo, and here we have a 7-minute acquisition 3D, which is a little bit longer, but still you have much more information. There is no fat saturation during the acquisition, but they took into account the fat contribution during post-processing, and you see that the values, they compare really nicely. Again, you need to further investigate impact of fat contribution in strongly fatty replaced muscle. When you look at the relation between water T2 and fat fraction, you see that there is this relation on the long term. So it showed you here some examples in GNA myopathy, in inclusion body myositis, and in dysphalanopathy. Here in the figure, you see a GNA myopathy patient which has a normal water T2, and you see this patient has an increase in quadriceps, which is rather spared, but this is known for this pathology, where you have an increase of 2%. If you then look at the patient, also GNA myopathy, who has a very high water T2, you see that this patient has an increase over 1 year of 12.4%. So there might be some predictive value of water T2 on what will happen in the near future. There's also water T1, so it's such as T2. It's an MRI property tied linked to the mobility of water in tissues. It's sensitive to the same pathophysiological mechanisms. Here's an example. It can be done with another sequence, which is called magnetic resonance fingerprinting. So more or less, you will acquire these kind of undersampled images. It's a sequence where you are going to vary flip angle, echo time, repetition time, and you're going to apply in post-processing a dictionary where you with simulated images, where you have simulated with different flip angles, echo times, repetition times, you will do a pattern recognition matching, and you will extract water T1 maps and fat fraction maps. Again, just for completion, I tell you that you can also extract T1 with spectroscopy. So advantages is you have simultaneous water T1 and fat fraction measurements in short acquisition times. There are now 2D and 3D options. Research now to extend to whole body. I show you an example just after, and it's not yet a sequence here that's easily available on most MRI clinical systems. Again, the same advantage and disadvantage for spectroscopy. So here, water T1 and T2 metrics, they are highly correlated. I show you this example here. In immune-mediated necrotizing myopathy, we see that T2 is increased in soleus and in some part of the gastrocnemius medialis, and we see more or less the same thing with water T1 mapping. Similar as for water T2, global T1 is not the same thing as water T1, so fat fraction is an issue. Take that into account. So these are a few examples you can do in 30 minutes. It seems long, but you have whole body quantitative data. You have fat fraction map, you have a T1 map from neck to ankle. You have also, if you then zoom into the trunk part where we want to image the diaphragm and the respiratory muscles in general with a resolution of 1.1 by 1 by 5 cubic millimeter. So in 15 minutes, you have a simultaneous fat fraction and water T1 map. All right. Just for completion, there's also a nice study done in 2025 with ultrasound on the diaphragm, where they used a machine learning approach based on texture features, just to have a reproducible way of longitudinal measurement of diaphragm changes, knowing that changes can be in the order of 0.2 to 0.3 millimeter. So that's a study to check out. Very shortly, diffusion MRI, again, like water T1, water T2, it's a property titling to mobility of water in tissues. It's a biomarker that can be sensitive to changes in muscle microstructure. So you have water molecules that move over a certain distance over a certain time. When you apply that to imaging, you can extract values such as mean diffusivity, the diffusion average over all directions. So you have stronger diffusion along the muscle fibers than across, than a transversal. You can extract a value which is called fractional anisotropy. So to explain, in normal muscle tissue, you would have a fractional anisotropy value that's high. What does it mean? It means that you have preferential water diffusion along the muscle fibers. If you would have inflammation edema, you would have a fractional anisotropy that decreases. You would have a disorganization of an increase in disorganization of your muscle fibers. You would have a diffusion that increases. In dystrophy, it's a little bit more complicated. You could have an FA that decreases and a diffusion that can increase or decrease. A very short slide, which I'll let you appreciate in your own time. You need to be very careful when you set up your diffusion protocol, because it's very dependent on your acquisition parameters. It can be quite powerful if you do it right. So you need to check your B-value. The B-value is an acquisition parameter which determines the diffusion weighting. Though in there you have the diffusion time. In muscle, you will find publications often diffusion times around 25 to 30. That's quite short. You need minimal p-values at 0 and a non-zero value. And also the number of diffusion encoding directions. If you do it in one direction or to some extent 2 or 3, you can only extract a sort of mean apparent diffusion coefficient. No, you cannot extract mean diffusivity. You cannot extract fractional anisotropy. For that, you need 6 directions or more. In publications, most of the time you will find 6, 12, or even 15. So more B-values, more directions is more acquisition time. The advantage is that you are sensitive to microstructural changes, but it's quite lengthy and it's also strongly impacted by muscle fat. There are many studies in recent years in diffusion. I'm not going into detail. Let you appreciate yourself if that interests you. You will find that there are significant changes for mean diffusivity and fractional anisotropy, depending on the disease and depending on the anatomical target. These have been done with different protocols, different B-values, different number of directions. Often you have also this impact of high muscle fat fraction, and there's lots of data. There's no standardized MRI protocol. Often they're very small sample sizes. Very briefly, if you want to put it in a little bit into context, if you look into translational MRI research some years ago in a mice model, this was done at 70, where they did diffusion from shorts. As I told you that in clinical they used around diffusion times around 50, but they added diffusion times to high diffusion times, and they found that if you go to higher diffusion times, that the difference between the MDX mice and the wild type mice was more clear. If they did correlated it to histology, they found that there was a much higher uptake of Evans blue dye in MDX. So this was an indication of an increased membrane permeability. Even before that, there was a group that worked on a model which called the Random Permeable Barrier Model, RPBM. This is based on diffusion data. So with this diffusion data and with this model, you could extract values such as the fiber diameter, membrane permeability, diffusion coefficient. So, and then you have to acquire multiple B-values and diffusion times. So in the MDX mice, they compared that also with histology, so the surface to volume ratio, which they extracted from this model, and they compared that to the perimeter over area of histology, and they found that there was an increased fiber diameter, both in vivo and ex vivo data. A few years later, they did the same thing in BMD patients, Becker muscular dystrophy, and they found, so the red is the Becker, where they found with this diffusion MRI and the RPBM model that there was a higher fiber diameter in Becker patients. And they correlated that, or they confirmed that with the laminin staining, where they also find that the BMD patients had a higher fiber diameter. All right. Just for completion, there's also some studies doing more exotic things, such as sodium and potassium MRI. This can be done in dysphallonopathy. So this is sodium. Higher sodium is found in dysphallonopathy patients. This in another study in Duchenne muscular dystrophy, in a longitudinal study, they also found that the sodium content was higher in Duchenne muscular dystrophy. And then they went one step further. The group, the same group in FSHD, where they did not only sodium but also potassium, and they found that potassium was lower in the FSHD and the sodium was higher as compared to the controls. You need, of course, additional hardware, and you have, as always, you are impacted by fat. So also pH, quickly you can extract that using spectroscopic methods, phosphor spectroscopy. So some of these metabolites, they have a frequency that's sensitive to pH, and you can extract these pH values, and we have seen that they have more alkaline pH values in many muscle diseases. So it can be used as a biomarker. Of course, as I said before, multiple occasions, MRS has no spatial information, and when you do MRSI, there's a suboptimal spatial resolution. Could we do pH mapping? So we try to work on a method with using CEST, where you're going to exploit the exchange between hydrogens such as hydrogens from creatine and the bulk water. You can exploit this exchange, which gives a signal which will lead to a value of your exchange rate between the mobile protons of your metabolite and the bulk water, and from this you can extract a pH value and a pH map. So this is ongoing. You have, of course, increased spatial information, but these CEST sequences are not available on are not available. I'm sorry, there's a mistake here on most MRI systems, or at least they are available on most MRI systems, but they are not optimized for these kind of applications. Fibrosis, to be quick, there's many of these biomarkers are sensitive to changes in fibrosis, but there's not one that can really say this is fibrosis. For instance, extracellular volume that's used in cardiac MRI, you can extract it by acquiring T1 mapping before and after contrast agents. This was done in a mouse model, an injury. We see that the collagen increase with collagen that's increased. You see that the ECV is increased, and we see when you then use the ECV measurement between injured and control, you see that in some of these injured mice, you have an ECV that's increased. This was done in dog model as well. You see the ECV is increased in the GRMD model. Advantage is that the GRMD model doesn't show a lot of fat, so you're not really affected by it. This was also done in Becker muscular dystrophy, where you have the impact of fat, but here there was also an analysis done where in Becker patients where there is a very low amount of fat fraction, and we see that there's a significant increase in the extracellular volume. Other methods for fibrosis is MSOT. This was done a few years back. MSOT, so you have an ultrasound and you have an optoacoustic element. You can extract information on metabolites such as hemoglobin, melanin, lipids, water, and collagen, and based on their absorption spectra that you can extract. This was applied in dystrophic pig model and DMD patients, and you see that here in this DMD, there's an overlap of the different metabolites. See that these blue, greenish image show you that there's an increase in, or would be related to so an MSOT of signal of collagen that's increased, and they showed that that was significant. There's a drawback. There are overlapping signals, so these absorption spectra, they are not overlapping. So not notably the one from hemoglobin and fat. So very few studies are performed. So we need more data and studies, and specifically validation with histology and is necessary. Collagen-based histology. Ultrasound is used for fibrosis. The echogenicity analysis, where you have here a normal rectus femoris muscle, and then you have here an FSHD, vastus lateralis muscle, which is normal on the fat fraction, but you see here the echogenicity is increasing in the vastus lateralis muscle. It would be an increase in fibrosis. But again, this is impacted if you have higher fat or edema, you would have also increased echogenicity. Shear wave elastography is also used, measuring the stiffness. Again, stiffness is increased with fibrosis, but there's also changes that are not specific to fibrosis. And ultrasound is difficult to apply for deep muscles and difficult to standardize across systems. Elastography with MR can also be used, so we end up again with MR. This again measures stiffness, and this time can be used for deep muscles, but there are very few studies now in NMD. There is one in 2024 in Becker patients, actually. Paradoxically, they found a decrease in fibrosis. Normally, you would have an increase, but the authors claimed that that would probably be related to the fact that these Becker patients were quite highly replaced by fatty muscles, and this would have affected the stiffness, as fat is less stiff than muscle tissue. So need for standardized protocol. It's quite promising, but we need more preclinical clinical data, and probably also at the beginning validation with histological assessment of fibrosis. I finish with this. This is a nice application of imaging of fasciculations. So the advantage of this is that you don't need to have a fancy imaging sequence, so you can do it with a very simple diffusion weighted sequence. And you will have to count. You have to acquire it at multiple time points, and you will do a counting of the voids that you see. And they saw that in ALS patients that you have an increased fasciculation rate compared to controls. They did that in the tongue, in the upper limb, and in the lower limb. They did that also in other diseases such as in mitochondrial disease, and at least also in an aging population. The data in SMA they did not publish yet, I think. So it's a great application. It has lower temporal resolution than the gold standard for this kind of application, such as EMG and ultrasound. And you would need electrical stimulation setup when you want to do a controlled imaging of the motor unit area. So I'm not going to go too much into detail in my summary. So the Dixon type sequences, there are quite a lot. You have to look at your acquisition parameters, but they are available on all clinical MRI systems. Water T2 mapping, you use a multi-TE sequence. They are also available on most systems, or if not on all, mostly a 2D sequence. Take into account or look at the number of echo times if you set it up. Is there fat suppression? Which post-processing do you use? Water T1 mapping, there are sequences such as MRF available. They can be used before and after contrast to extract ECV, and they can also be done in the whole body. Then there's the diffusion. That's also, again, a family of sequences. Not all of them are quantitative. Check definitely which B-values you want, also what you want to do. Specifically with this diffusion protocol, the diffusion times are important, the number of diffusion directions. And if you do an advanced protocol with the RPBM model, you can extract parameters such as fiber diameter. Fibrosis, there's no direct measurement using QMRI. The closest is ECV. MR elastography is only the beginning, and we need validation. We need more studies. MSOT is also promising, but there's also overlap with many metabolites. We also need more data, and we need validation with histology. There's no standardized protocol. Ultrasound is quite sensitive to increased fibrosis, and is for superficial muscles a good idea. Take into account if there's fat and edema. There's CEST and magnetic resonance spectroscopy for more advanced applications, metabolic applications. And beyond the lower limb skeletal muscle, there's respiratory muscle in the whole body. I showed you the example of MRF. Automatic muscle segmentation will reach beyond lower limb muscle, so there will be much more data to exploit. We have the application of MRI fasciculations. Nerve cardiac imaging, there's also a nice application that I didn't show you. And remember, if I haven't said it already 100 times, fat is a confounding factor for almost everything that I've shown you, so that always needs to be taken into account. So there's many other videos. There's also quite a lot of conferences that you can go if you're interested in these applications. And with that, I thank you for your attention. Sorry to have taken a few more minutes.
Well, thank you very much, Harmen, for this comprehensive, very dense lecture. As we discussed before starting, I mean, the webinar will be almost immediately online, so people can go back and review at their own pace all the informations that you've given us. I don't know if anybody. We still have a bit more than 20 participants. If anyone has a question, either for Giorgio or for Harmen. I do not see any question popping up. So while people will still be thinking and maybe come with an interesting question. I have one for Giorgio. You will forgive me, Giorgio, because it's a recurrent one. Well, identifying patterns of muscle infiltration and replacement in relation with different genes is an ever-growing field, almost in itself. Now, as a clinician, as you know, for these genetic diseases, with all the progress of the existence of panel, exome, and even when needed, the genome sequences, well, I think that it's progressively reduced the field and the impact of muscle imaging. I might be wrong, so you may object against that. But more specifically, what are the genetic diseases where imaging will still have a real strong impact, or even is necessary in the area of advanced genomics?
Yeah, so well, of course, this is a very important and question, and also quite difficult to answer. So, of course, I mean, the diagnostic imaging in the last years has changed its role more and more as a tool to help the interpretation of gene panels, where, of course, those are available and those are run in the first instance. In the diagnostic workup of a patient. So we of course have learned through the years that there are a few diseases for which we can say that the imaging pattern is really specific, and there are also a handful for which is probably we can still use the word pathognomonic. But of course, one thing we need to keep in mind is on the one end, that not all the muscle disorders are necessarily genetic. So not all the neuromuscular patients can be solved with an exome or even with a genome, because some of the genetic neuromuscular diseases are not captured by standard whole exome sequencing. And also, I mean, it becomes more and more evident that the interpretation of some of these variants, depending on the thresholds that we use to attribute pathogenicity to those, the interpretation is particularly challenging. So it happens more than often, I would say, that you can even get an apparently negative exome result that you would then want to reinvestigate based on some clinical or instrumental findings, and those, of course, need to include the whole picture, meaning clinical findings, muscle pathology, and imaging as well. So I mean, to answer your question, I still think that there's gonna be a role for that. Of course, we need to take into consideration the fact that the final answer that we want to achieve is a genetic answer for genetic neuromuscular. But again, in the daily clinical practice, I mean, here in Newcastle, for example, we run weekly MDTs in which we re-examine examine the genetic data of patients, and it's not so unusual that, I mean, one good example of this would be you have a look at imaging findings in an exome negative patients, and those by themselves would let you suspect an FSHD or an inflammatory myopathy or an IBM or other types of those diseases. Of course, the role of these in the rarest entities is limited because our knowledge is limited. There might be a role for, you know, advanced tools that are non-human intelligence driven, if you wish, to that as well. But again, I don't think that this is currently useless or will ever become useless. Of course, we need to understand what the role of this will be with the increasing knowledge we will have in genetics and other modalities.
Okay,
This
thank
was
you.
super long, but the question was difficult, wasn't it?
No. Well, I won't go further now, but I mean, then probably we'll have another discussion. Well, we'll go deeper and go to specific diseases and try to come with something that might be helpful to everybody. I still don't see any question from the audience. I mean, if you have questions, please type them in the Q&A that is at the bottom of your screen, or ask to be able to speak, and Elizabeth will give you the floor. Harmen, well, all this is impressive. There are clearly progress in the quantitation, in the documentation of disease progression. There are some interesting results of the effects of intervention. However, and I'm referring to a review, very recent review, I think that the first author was Wilcox, showing that in fact, in clinical trials, the use of imaging is rather decreasing in the most recent ones. And then the question is, well, why is it so? Is it simply, the typical, the famous hype curve? Is it that imaging is just in the valley of the hype curve, and the people will understand the real value and it will re-increase? Or is it because of the so challenging issues of running multi-center trials, and multi-center trials are key in the evaluation of a treatment for rare disease. So,
yeah, I think it's probably a bit of both, I suppose. That's probably not the answer that everybody wants to hear, but it is like that. I cannot look into the future knowing if we will get out of this dip. It's true that there's a saturation. You see that in last conference, to everybody, more and more everybody is doing fat fraction and water T2 mapping. Nobody was doing that even a few years ago. They do that now in many diseases. There is no therapy, as you said, so we have very few treatments to evaluate these quantitative, these advanced imaging. And then if you combine that with the multi-center aspect, who knows, maybe those sites that have therapies are not doing quantitative imaging. I don't know. I would like to, it would be a shame, and probably we have to get out of there either with treatment or probably go a little bit more deep, and then it will become a little bit more fundamental using quantitative MRI to look for mechanisms. I think what's missing is multimodal. Everybody's doing fat fraction and T2, but it's like in silos. Everybody's done separately, and they do not combine these information. And if you then add diffusion, it's probably all those things need to be done. The advantage is that now more and more sites are convinced that they can do it and that they do it, at least specialized sites. I think we now need to pull everybody in. So even smaller centers and hospitals can also do these kind of high level or at least advanced imaging in the near future. So it's probably a combination of all those factors together. So maybe we'll have a few tough years to come, maybe, and who knows, maybe we'll see what we can do with quantitative imaging.
So future might be bright.
Well, I'm not also the most optimistic person, but let's be optimistic for this webinar.
Okay, well, thank you to both of you. I do not see any question. We are late, so I think that we are going to close here. Thank you very much. I repeat that, well, the webinar will be available very, very soon. So, well, and I'm sure that you will get many other viewers in the future. Okay, well.
Okay.
Thank you.
Thank you very much.
Bye-bye.
To the next imaging webinar, I hope that we'll have at least one in 2026. Okay, bye-bye.
Bye-bye. Thank you.
Bye-bye.